Thank you, Cynthia, and I'd like to thank you for inviting me here today. I always enjoy coming to New York, and I appreciate everyone who's here today to listen, and thank you for listening. These are my disclosures, and the ones that are relevant for this talk are Cassini and Lenzar. And I think this whole session is primarily about a 5-step process that we go through when we're performing refractive cataract surgery. Lisa talked about how we educate, which is our informed consent. We're going to have some of us talk about how we measure. And as a matter of fact, measuring is probably one of the hottest topics that we talk about, which is the topography and the IOL calculation and deciding what to put in the patient. So we set the expectation and we measure and we put all this effort into it, and then we get into the OR. We have to treat, and that's basically what my talk is about today, and then also tracking. So I'm going to talk about those 2 steps in the refractive cataract surgery process. So when we treat, we have to have a defined plan going into the OR, but it's always useful to have more than one plan in case something backfires, because anything can happen. So first, when we're treating, we're deciding where we treat, and we have to mark that axis that we're going to treat on. We have to consider that there's potentially some cyclotorsion when the patient goes into the supine position. So there are many ways that we can mark the axis in the pre-op area. There's a robo marker, a gravity marker. We've seen all these different things, and they're out there. And if that's all we have, that's the best we can do, because we can't go into the operating room not having clearly that axis marked. There are also automation methods which have to do with limbal blood vessel registration or iris registration, and there are devices that can do that for us prior to the cataract surgery. And then there are also intraoperative systems such as wavefront aberrometry or the Callisto or the IOL Compass Pro, just a few types of products. And then we'd have to decide how we're going to treat. Are we going to use astigmatic incisions, or are we going to use toric IOLs? And this may differ in our decision-making process based on whether it's with the rule of astigmatism or against the rule of astigmatism. Manual astigmatic incisions are still a legitimate way to treat low and moderate cylinder. They've been effective for years. We've used them in some situations. They may not be particularly reliable, but they may work for your patient. We also have femtosecond laser astigmatic incisions that we can make, and they are also useful for low and moderate cylinder. I do think that they are more reliable than the manual ones. And then we also have toric IOLs. We have low power toric IOLs now that are getting a lot of press because they're very successful in treating astigmatism, as well as the moderate and high cylinder lenses. So this is how I like to mark my axis. This is a refractive capsulorhexis. So you can see the funny looking capsulorhexis that this laser is going to make. There was 10 degrees of cyclotorsion in this patient, which you may have seen at the beginning of the video, where the whole system shifted to adjust for that. So the little nub in the capsulorhexis is where you put the hash marks for the IOL. And you should be able to see those little nubs when you remove the viscoelastic. If the lens moves off of the nubs, you just move it back, which is what we're doing here at the end of the case. So it makes it very, very simple. I don't have to mark in the preoperative area. I don't have to figure out if the patient had cyclotorsion when they went supine. It was registered with the laser, and the laser marked the axis in the plane of the lens. So how do we know if this is effective? Is it safe? Number one, is it safe? And then is it effective? So the only way you know is you track. So whatever method you're using to mark for your toric IOLs, you should know whether it's effective in giving you the results that you want. And this is because you have to close that loop. If you want to eliminate the waste and variables in your refractive cataract surgery system, you have to look at your results. That way you will be able to decrease enhancements and build confidence, and knowing your numbers just makes you more confident when you're talking to patients. This is a study that I am in the middle of. This is my initial data. I have 31 eyes. It is a prospective study, And we are looking at cherry-picked astigmatism correction. So these are patients that have beautiful topographies and great looking data going in. So we know exactly what axis we're treating. There's no dry eye, there's no variability. We know the axis. So is this system effective at marking this axis so we get good results for patients? And so we have 31 eyes at 6 weeks. They underwent femtosecond laser-assisted cataract surgery with a toric IOL, and the alignment of the toric IOL was guided by these capsular marks with the LENSAR laser. And these are the results, which I think are really awesome. The preoperative mean corneal astigmatism was about 2 diopters, post-op refractive astigmatism 0.11 diopter. But the chart to the right is really where the money is. You have all patients with a half a diopter or more of astigmatism, and then 100% of patients have a half a diopter or less. Now, I have about 20 patients left to get into the study. I'm anticipating that it might not be so good when I finish, but I think it's pretty good right now, and I was pretty excited about that. This is also a double-angle vector plot of pre and post-op, the pre being in the red and the post-op being in that tight little blue circle in the middle. So the results are important as well because you have to fix the problems that you have. If you don't hit your mark with the astigmatism correction, then you have to fix it, because just as Lisa was talking about earlier in the previous lecture, refractive surgery is more than just a procedure, it's a promise to a patient, and I think we should all do our best to keep our promises. In conclusion, how we treat astigmatism is one of 5 critical equal steps in being successful with refractive cataract surgery, and we must have attention to detail in eliminating wastes and variables, and that does include a commitment to the highest available technology to do so. And in that way, you can be the enemy of good. Thank you.